anti-thyroid antibody formation against the antigens of the follicular cells. So there is more production of thyroxine, and there is enlargement of the thyroid gland. So this is an example of a localized autoimmune disease in the body. Only the thyroid gland is involved. So the thyroid gland, there is formation of auto antibodies against the thyroid called anti-thyroid antibodies. So um this, as we already have done, that there are certain barriers in our body through which immune system or immune cells cannot pass. Brain have a barrier, the testes have a barrier, there are ocular barriers. So sometimes the immune system cells, they cannot pass through these barriers, and these tissues, they remain safe. But in cases of autoimmunity, when auto antibodies are formed, they can cause inflammation and complex formation in these areas. So these areas can be involved in autoimmune diseases. So eye is one of the areas in which you may have autoimmune scleritis, episcleritis, or uveitis. This is just a small table of autoimmune diseases, just to show you that there are diseases in which self antigens are involved, and autoantibodies are produced inside your own body against your own antigens. So you have hemolytic anemias, good pasture syndrome, which is a syndrome in which the kidney and lungs are involved, and the antibodies are formed against the basement membrane. Myasthenia gravis is another autoimmune disease. Graves' disease, Hashimoto thyroiditis, it is a form of chronic inflammatory thyroiditis. SLE is systemic lupus erythematosus. This is one of the disease we are going to discuss in detail today. Rheumatoid arthritis, the most common example of an autoimmune disease. Or rheumatoid arthritis is an autoimmune disease. Insulin dependent diabetes. So one of the variants is an autoimmune diabetes. So these are some of the autoimmune diseases out of many others. This is just a diagram to show you that autoimmune diseases may overlap. So there are certain susceptible genes in the body. Then there is epitope spreading or mimicry, as I told you before. And then there is exposure of the hidden antigens to the immune system, which were not previously presented, like the privileged tissues, or there are certain other antigens which are exposed because of a viral infection, because of a chemical or a drug injury. So there may be overlapping of these diseases, there may be overlapping of the symptoms of these diseases. So clinically, a good history, detailed examination, and then the serological tests, in which you have to particularly go for one particular antibody for that disease, will make up the diagnosis. So this diagram shows that any organ of the body can be involved in thousands of named anti autoimmune diseases. So the previous table showed you some of the common autoimmune diseases, but there is a long list of autoimmune diseases. And that's why I told you earlier that immunology is a separate branch in which we deal with the immune system and the diseases related to the immune system. So let's deal with some of the common im- immunological diseases or autoimmune diseases. So number one is rheumatoid arthritis. I'm just going to give you just a very brief account of rheumatoid arthritis, because this is what you are going to go into the detail. in your fourth year in bones and joints. But because we are dealing with autoimmune diseases, and this is one of the prototype example of an autoimmune disease. So antibody is directed against the FC portion of IgG. It is not diagnostic of rheumatoid arthritis. So you have to go first for a good history, the clinical picture, examination of the joint, radiological findings, and then the serological test is going to support that this is rheumatoid arthritis. Rheumatoid factor is actually the autoantibody. Rheumatoid factor is also called RA factor. RA factor is also present in certain other uh, autoimmune diseases also. So it is not the diagnostic just of rheumatoid arthritis. So what is RA factor? RA factor is an antibody, autoantibody directed against the FC portion of IgG. It can be used in other diseases also, in certain chronic diseases also. And so RA factor, when we order an RA factor and it is positive, or the levels of RA factors are more in the serum, it means that you are dealing with an autoimmune disease. It doesn't mean that you are dealing with a rheumatoid arthritis. If I get a sample from a patient and I give a report that RA factor is positive, that doesn't mean it is rheumatoid arthritis. You have to correlate that report with your clinical history. If the patient is coming with a joint problem and you have a good clinical history of arthritis, then it may suggest that it is rheumatoid arthritis. So rheumatoid arthritis, RA factor is one of the supportive um, investigation, not the diagnostic investigation. The diagnostic investigation for rheumatoid arthritis is a biopsy of the synovial membrane. So this is just to show you what rheumatoid arthritis is. It is a joint inflammatory disease. So there is formation of autoantibodies against the synovium and the synovial membrane. There is inflammatory reaction, and there is a huge destruction of the joint space, the bone, the cartilage, and the synovium itself. So there is deposition of autoantibodies, complex formation. There is initiation of the inflammatory process, which turns into a chronic inflammatory process. And then you all know what happens if the mediators are released, and there is destruction and uh, repair of the joint. So as we did in the definition of the chronic inflammation, that the destruction and healing is taking place simultaneously. So same way, both the mechanisms are taking place simultaneously in rheumatoid arthritis. So there is decrease in the joint space, and lastly there is pannus formation, that is the inflammatory slough that is formed because of the destruction and repeated repair and healing. So the patient may uh, end up in a miserable state. So you have to diagnose it early and treat it early. So not going into the details of the histology and the clinical features, it was just because we were dealing with autoimmune diseases. So this is one of the prototype common disease. Another disease which you have to know in your third year is SLE, that is systemic lupus erythematosus. Systemic because it involves more than one tissues of the body. Lupus erythematosus is that you might have heard about erythematosus, you might have heard about lupus, you might have heard about lupus erythematosus. Make it very clear that erythematosus means redness on the skin. Erythematosus is a term in dermatology which is used in a number of dermatological diseases. Lupus again is one of the terms in dermatology which is used for in many of the names of dermatological diseases. So lupus vulgaris is not an autoimmune disease. It is tuberculosis of the skin or the dermis. So lupus reaction is another term in dermatology. So make it clear that when you are dealing with an autoimmune disease, that is systemic lupus erythematosus. Not all systemic lupus erythematosus, or sorry, no all lupus erythematosus or lupus or erythematosus are SLE. If you are dealing with SLE, you have to take its full name. So the other person realizes that you are talking about the autoimmune disease and not any other dermatological disease. So this is a very big mistake clinically. Uh, if you say lupus erythematosus, that means that you are dealing with something else. But if you particularly say that it is SLE, systemic lupus erythematosus, that means that you are dealing with an autoimmune disease. So, systemic lupus erythematosus, we are dealing with an autoimmune disease now. It is one of the prototype of autoimmune disease. So, whenever you have to discuss a mechanism of an autoimmune disease, or you uh, are going to list autoimmune diseases, this is the number one disease which is on the top of the list. So there is loss of tolerance to the self antigens, and there is loss of tolerance in the immune system. So there is formation of auto antibodies against the self antigens. The etiology is unknown. Unknown means that a single etiology is not known. But as I said, that all the theories about the viruses, the drugs and chemicals, they exist, and they are also true for systemic lupus erythematosus. But if we say that what one etiological factor is the pathogenic mechanism for SLE, that is not unknown. Sorry, that is not known yet. So that is why it is unknown. It is not that there is no etiology. You might have a single etiological factors. After some years we might discover one, but yes, sometimes you have a history of any exposure to the chemical, or long-term drug exposure, or certain viral diseases in the history of SLE. So you have to take a history. And the last point is each patient is unique. That means that each patient of SLEs is going to present with a new sign and symptom, maybe with sign and symptoms which are not related to SLE, maybe sign and symptom of the tissue or the organ which is involved. Um, so the patient is never going to present with a sign and symptoms that you can particularly pinpoint clinically that this is SLE, but certain collection of sign and symptoms may lead to the diagnosis, and then you have to go for certain serological tests also. This is just to show you that there are certain drugs which can induce lupus reaction. This is not SLE. This is a lupus reaction. So this is an allergic hypersensitivity reaction to the drugs, and the patient may present with reaction to these drugs. One thing is that you have to stop all these drugs and then go for the treatment. So this is lupus inducing drugs, or in dermatology we are going to call them call the presentation as drug induced lupus. So this is not SLE. So systemic lupus erythematosus is again more prevalent in females than males, and more common in the people of African descent, but it is not uncommon in our country. You may see people in the outdoors. That is that you don't have to actually miss the autoimmune disease. So the patient may present with facial erythematous rash, which is called a butterfly rash. I'm going to show you in a while. Photosensitivity of the skin. Patient may present with alopecia, that is loss of hair, oral ulcers, which are called aphthous ulcers. Then may present with arthritis. That is that patient is not coming with any deformity, but symptoms of arthritis or joint pains. So first you have to rule out rheumatoid arthritis and other common arthritis. If you don't come up with the diagnosis of those arthritis, then you may think of an autoimmune disease. Then psychosis or fits, that may also be one of the symptoms. This is a typical butterfly rash, that is a rash on the nose and the cheeks. So again, that this is not only particular to SLE. This type of rash may also be seen in other dermatological reactions also. So again, a good history and clinic examination is very important. A female in 20 to 40 years of age with this rash and a history pertinent to an autoimmune disease uh, may end up in SLE. So these are the most common areas involved. So face is one of the most common areas, as you see the pink color. This is the area involved by the rash. The purple area is a common area, and the green one is an uncommon area. And the genital area and the lower part of the trunk is one of the rare areas where you can see the rash. So these are some of the other organs which are involved in SLE. You may have butterfly rash, you may have involvement of the heart or the lungs, and the patient may end up as presenting with pleural effusions. Patient may present with arthritis. Patient may present with Raynaud's phenomena. Raynaud's disease and Raynaud phenomena are two different terms. Raynaud disease is a vasculitis, while Raynaud phenomena is something else. That is when you put your hands in cold water, the fingers they are going to turn blue, and when you take them out, they are going to turn normal. So that is Raynaud's phenomena. Again, Raynaud's phenomena can be seen in more than one diseases. It is not particular of SLE. In many other autoimmune diseases also, uh, you may see Raynaud's phenomena, and that is because of the involvement of the vessels and small uh, vessel vasculitis. That means that small sized vessels are involved, and anti bodies are directed against the antigens present on those small vessels, and they are involved in inflammation. So when you put your hands in cold water or ice, they turn blue because of cyanosis. The patient may present with symptoms of renal diseases, or it is called lupus nephritis. 50% of the patients of SLE presents for the first time with renal nephritis, or lupus nephritis or renal symptoms. And eventually every patient of SLE, almost every patient of SLE, is going to end up in having at least the renal failure or the renal problems. So kidney is one of the organs which is most commonly involved in this disease. So this is Raynaud's phenomena. The fingers they turn blue, and then they get re vascularized, and you have dilated vessels, and the fingers get pink again if you take the fingers out. So, clinical symptoms are not particular in a way that if you see this chart, you may have arthritis, you may have fever, you may have fatigue or weight loss, you may have rash, you may have vasculitis, you may have nausea, vomiting, or abdominal pain, you may have renal symptoms, you may have hematological symptoms, and symptoms related to heart and CNS. But see this, that no one symptom is just pinpointing SLE. These are all the symptoms which are present in many of the other diseases also. So once the patient is presenting with these symptoms, you always have to rule out other common diseases first. That is why I was saying that autoimmune disease remains at the bottom of the differential diagnosis, but uh, the emphasis is that you don't have to miss autoimmune disease. Systemic lupus erythematosus, 50% of the patients experience kidney damage, and autoantibodies are directed against the antigens on the glomeruli. So this is one of the types of glomerulonephritis, and the person dealing with it is a nephrologist. You don't have to go for the nephrectomy. You have to deal with medicines and certain other therapies, immune therapies, and a nephrologist is going to first diagnose this case as a glomerulonephritis. Glomerulonephritis is inflammation of the glomerulus. You're going to study this in detail in your fourth year in kidney. Glomerulonephritis are of many types. So, systemic lupus erythematosus is so you don't have to remember this in third year, but this is just to show you that there are a number of types of glomerulonephritis, starting from 1, 2, 3, 4, 5, and 6. So there is a minimal meningeal disease, there is meningeal proliferative disease, focal glomerulonephritis, diffuse glomerulonephritis, membranous glomerulonephritis, in which there is proliferation of the membranes uh, in the glomerulus, and then there is advanced sclerosis. So, patient of lupus erythematosus may present with any of these, and one of the cause of deaths in a patient having SLE may be a renal failure or a cardiac failure or a respiratory failure. So the disease itself is not going to kill the patient initially. It is because of the failure of the major organs. So musculoskeletal system may present with these few sign and symptoms. You may end up in myositis, which is inflammation of the muscles. Um, Again, you don't have to remember this. I'm just showing you that you are going to study this in your medicine. uh, this is one of the criteria for SLE. So you have butterfly rash, you have discoid rash on the other parts of the body. Discoid means disc like rounded rash. You have photosensitivity, you have oral ulcers, you have arthritis, you have serositis, that is inflammation of the membranes in the body cavities. Then you may have a renal, neurological, or other disorders. And then anti-nuclear antibody is important in the diagnosis. So if you have such uh, symptoms clinically, you may think about SLE and go for the serological test. So, what about the autoantibodies in SLE? Anti-nuclear antibody, more than 95% of the SLE cases, they present with anti-nuclear antibody. But it is also positive in 10 to 15% of the normal persons also. And anti-nuclear antibody is also positive in many other autoimmune diseases. So first, you have to order ANA, that is because you are ordering to rule out autoimmune disease. And if you have clinical symptoms of SLE, which we discussed in the previous slides, you are then going to order two more antigens. Those are anti double stranded DNA antibody, that is marker for the disease activity, that how active the disease is. And then you have to order anti-Smith antibody, anti-SM antibody, that has a high specificity for SLE. So three antibodies. There are many other antibodies produced in SLE, but these three antibodies are enough to make a diagnosis of SLE. So ANA is to rule out an autoimmune disease. Anti-DS DNA antibody and anti-Smith are particular for the SLE. So anti-DNA or anti-double stranded DNA antibody is going to tell you the activity of the disease. So the amount of this antibody is going to vary during the course of the disease, and you can tell from the levels of this antibody that how active the disease is. Once there is an autoimmune disease, you cannot treat it fully, but you can prevent the complications, and you can prolong the period of the development of the complications. uh, there is no one particular treatment for autoimmune diseases, but yes, you have this autoimmune disease is lifelong, but you can make the life good for the patient with certain treatment options. So, in case of SLE, you have to remember ANA, anti double stranded DNA antibody, and anti Smith. If there is an MCQ, that which antibody is going to diagnose SLE, that is anti DS antibody and anti Smith antibody. Uh, you don't have to go for this slide. This is just to show you that certain genes are also involved in certain cases of SLE. So just to show you that the mechanism or the pathogenesis of the autoimmune disease is not very simple. It involves a number of mechanisms. So what is the management? The management is just supportive according to the involvement of the tissue or the organ. So you may give painkillers, you may give anti-steroidal, anti-inflammatory drugs, you may give corticosteroids, injectable or oral, according to the condition of the patient. And then certain immunosuppressive therapies or cytotoxic drugs may also be used. Immune therapy is one of the options, but in cases of SLE, immune therapy is not yet well developed. So, systemic lupus erythematosus, please make it very clear: systemic lupus erythematosus and lupus or erythematosus, these are different things. Another disease is scleroderma. Sclero means fibrosis, derma means in the skin. So, scleroderma or systemic sclerosis is another name for scleroderma. That means that it is not just in the skin. Scleroderma is that it starts with fibrosis underneath the skin, but it may involve other organs also. So if you are saying scleroderma, if you are saying systemic sclerosis, that is one of the advanced forms of scleroderma. So, scleroderma is a progressive systemic fibrosis. Females are more prone to develop this disease than males. Affects skin and produces a mask-like expression of the face. It may involve kidney, lung, heart, muscles, and GIT. And then there is CREST
Sorry to
syndrome.
interrupt you, just 4 minutes left.
Okay. So there is CREST syndrome, that means calcinosis. There is deposition of calcium in areas which are damaged, and this calcinosis is actually dystrophic calcification, which we did in the first chapter. Raynaud's phenomena, not disease, it is Raynaud phenomena. Esophageal dysfunction because of the fibrosis in the esophageal stroma. Scleroductally, that is elongation of the fingers, that is again because of fibrosis in the dermis. And then telangiectasias are small hemorrhagic spots on the skin, again because of the inflammation and the fibrosis. Because of the fibrosis and the inflammatory process, small blood vessels, they get ruptured, and there is collection of blood underneath the skin, so that forms a pinpoint or pinhead red spots. So this is scleroderma. There is fibrosis, and whenever there is fibrosis or whenever there is deposition of the collagen fibers, they are going to contract. So that is why they are going to deform the joints and the fingers. So this is a typical clinical picture of a patient with scleroderma, long fingers. That is not that fingers are growing. A- it is that the fingers are having fibrosis underneath the skin, and that contractions is actually contracting or squeezing the skin overlying the bones. So that mimics that as the patient is having long pointed pencil like fingers. This is a beak nose, that is again because of the fibrosis. There is fibrosis, and when the fiber contracts, this is the typical facies of a scleroderma patient. So you have a beak like nose and you have a fish like mouth. Scleroderma can be limited to the skin or can be diffused. Scleroderma is localized or systemic, and these are some of the variants. You're going to go into the details of the variants in dermatology in your final year. For the time being, you just have to remember that scleroderma can be localized to the skin or can be systemic. So this is what is systemic picture of scleroderma. You have calcinosis, calcium deposition in the skin. You have Raynaud's phenomena. You have esophageal dysfunction, because of which the patient may have reflux esophagitis. You have fibrosis in the lamina propria of the esophagus. You have sclerodactyly, that is long pointed finger, and then you have telangiectasias, that are small red marks because of the capillary damage. So that is called CREST syndrome, and that is the advanced form or the systemic form of the scleroderma. This is telangiectasia, dilatation of small vessels and then rupturing of those capillaries, forming a blood collection underneath the skin. That is called telangiectasia.
Okay, sir, lecture time is over now.
Okay, Ji, we are going to continue this in the next lecture. Thank you so much.